Fairbanks are the biggest
Or it's in the same place.
No, you gotta.
You have one for later, man.
Yeah, I mean, you can write for
All right.
Yeah, it's the regular invitation time, place.
looks out this way.
I know you can see you. Yeah. That's why I stand aside. Yeah. Once they start talking, they'll see you. See Len. Are you
So where are they from? Where's the east side? You've been playing them.
Yeah.
You've been playing them.
There's one on the they decided to start playing. Well, I couldn't have turned it. Oh, that'll be a way. Big house.
Oh, really? You got a tough schedule, lady.
I think I can make it.
Still fighting my
And she had no response at all to the request.
Yeah, I mean, that's the problem.
Right. And not probably that's okay. Okay, that'd be great. Okay. Since now you're
Anyhow, you know, you're always
just been filling out the form.
Anyway, that's never come like now. Yeah, right. You go really nice. I'm right across the aisle from the one that they twice as much as after 30 years. Anyhow, so I was upper deck about 30 years ago. Well, you look straight up.
Oh my God.
Let's go ahead and get started. We've got quiet down. Everybody listening? Hello? Enough already. Let's go ahead and get started. We got a big agenda. People take journals very seriously now, so we've got 3 speakers this morning on diverse topics. The word of the day is immunity for CME credit. The only other announcement is a reminder that our last session, our dinner session, is going to be the 29th. I'll send out the invitation today, so that's a Thursday, not a Tuesday, and not here, but over at, I still call it TEL. What's the right name for the place? Huh? Teleris? Yeah. Anyway, so I think Audrey's going to start, Bill's going to go next, and then Mary. So you got to be quick here, about 20 minutes apiece.
So today my topics, the title is called Group 2 Innate Lymphoid Cells, which is a novel cell group that we're going to talk about in a little more detail, and it seems to be a critical spark in asthma. So I have no disclosures. So as we know, asthma, we really think for years now that it's mediated by adaptive immunity, primarily the Th2 cells, and rightly so. IL-4, IL-5, IL-13 are very important in many of the hallmark features that we see in asthma, such as elevated IgE, eosinophils, and airway hyperreactivity. But as we also know that there are non-allergic asthma phenotypes, and so asthma can be induced and triggered by pollution, smoke, viral infection, as well as obesity. So how do we sort of reconcile, and how do we determine what the actual causes are in a pathological sense? So the innate lymphoid cells seem to be sort of the missing link between these two groups, and we'll talk about that in more detail. And it's really quite actually amazing that we hadn't heard about innate lymphoid cells earlier. I think there's just been so much focus on the adaptive immunity of the T cells and the B cells, and so basically Andrew McKenzie, who's one of the big groups that is looking at lymphoid cells, said, perhaps we were just gating them out, and that's true. I mean, even with all my PhD work, I was focused mainly on Th2 cells, and absolutely, I would gate all those things out, even though I had seen even that there was some, IL-4 cytokines being made. So innate lymphoid cells, the first time that it was described was in 2001, actually, in immunity, and it appeared that they were a non-T cell, non-B cell population that expanded in mice treated with IL-25. And IL-25 is a very important cytokine made by epithelial cells and seems to be elevated in patients with asthma. And so they saw that when they injected the IL-25 into the mice, you would get an increased Th2-like profile, so elevated IL-4, IL-5, and 13 production, and an increase in serum IgE and eosinophilic infiltrates in the lungs and the GI tract. But several years went by, and really kind of this paper came a little bit unnoticed until 2010, and then there were 3 groups that almost simultaneously published the finding of these innate lymphoid cells, showing that they could be found in the mesenteric lymph nodes, spleen, liver, and intestines. So The innate lymphoid cells, there's actually a very good review in the recent April edition of JACI, and it seems like they share some common features. One, that they don't have the rearranged TCR or BCR sort of receptors. So they're non-T cell, non-B cell lymphocytes, and they're found primarily in the mucosal lymphoid tissues. And they're not surprisingly, because they're not have particular or rearranged receptors, they're non-antigen specific, and they seem to secrete multiple different kind of cytokines. So interferon gamma, IL-5, 9, 13, 17, and 22. And unlike the adaptive immunity, these cells tend to respond much more quickly, so within 1 to 2 days to environmental factors. So this slide shows sort of a compilation, a summary of the new classification of the innate lymphoid cells, and it embodies a lot of work done by multiple groups. What we know so far is that the initial arrow here, that the precursors seem to derive from cells that express the ID2, which is the transcription receptor repressor inhibitor of DNA binding to, big mouthful of words. These cells also express the common cytokine gamma chain, and then in response to IL-7, they can turn into innate lymphoid cell group 1, group 2, and group 3. In the group 1, cells are very much like natural killer cells. They need T-bet expression, and they make interferon gamma. But unlike natural killer cells, they do not express perforin, granzyme B, or killer cell immunoglobulin-like receptors. And they don't seem to respond so much to IL-15, but instead respond to IL-7. And these cells seem to be important in Crohn's disease. The group 2 population seems to be dependent on the ROR, or the retinoic acid receptor-related orphan receptor alpha, and also GATA3, which we also know is important in Th2 development. So these cells can be found in the mucosa as well as in the skin. In the skin, these seem to respond to the epithelial cytokines of TSLP and make IL-4, IL-5, and IL-13, and so it seems to be very important in atopic dermatitis. In the mucosa, however, these cells tend to respond to IL-25 and IL-33, producing very similar sort of Th2-like cytokines, so IL-5, 13, and 9, and seem to be important in different kind of asthma models. And of course, this is mainly done in in mice at this point, but so for flu, for ova-induced models, as well as fungus. And so there was actually a very important paper that came out in Nature Immunology a couple of years ago by Dale Umetsu's group, and they showed that when influenza infects the macrophages of the airway cells, it produces IL-33, which then induces the innate lymphoid cells 2 group to make IL-13, and this is what actually leads to the airway hyperresponse that they see in those mice, and this is independent of T and B cells. But on the flip side, besides just mediating actual pathology, it seems like perhaps these cells are actually important in protection. So another group showed that the flu-activated group 2 innate lymphoid cells produce this chemical called amphiregulin, and this is important in restoring lung tissue homeostasis, so it's actually important sort of dampening the immune response. There have been a lot of different names of the innate group lymphoid 2 cells, as you can see here, but right now, based on the new classification, we're kind of grouping them all together into this one. And it's important in mediating eosinophilia and the goblet cell hyperplasia. So some of the initial papers looked at helminth infections, and so it's important for helping clearing those infections. And then pertinent for us is for working with humans and not mice, these cells are actually increased in the nasal polyps of patients with chronic rhinosinusitis. And then the group 3 population, unlike the other ones, seem to be important, need the transcription factor of ROR gamma T, And there are three different subtypes of group 3. The first one is the lymphoid tissue inducer cell subset. They all share in responding to IL-23 and IL-1, but this particular subset is important in lymphoid tissue organogenesis. The second subset actually also needs TBET and another transcription factor, AHR, which stands for aryl hydrocarbon receptor. And these make IL-22, which seems to be important in psoriasis. There's also some thought that there may be some fluidity so that some of these subsets can downregulate their the ROR gamma T and then actually become the sort of the lymphoid subset 1. And then finally, the third subset for the group 3 innate lymphoid cells are ones that seem to be more important in obesity-induced asthma as well as in Crohn's disease, and they produce IL-17 as well. So you can see this paradigm sort of mimics a lot of parallels the universe that we know of TH cells. So the TH helper cells of 1, 2, making interferon gamma, and IL-4, and then also the TH17 cells. So it seems like there's a parallel world in the innate immunity.
Audrey, maybe you said this already.
Yep.
Since they're not T cells or B cells,
Yep.
what's triggering them? What's their stimulus?
So basically cytokines from the epithelial cells. So we'll see that a little bit more. So in interest of time, I really just focused on one particular paper that came out in the March edition of Immunity, and it's from the group of in Vancouver and then Andrew Mackenzie. And so what they were looking at is, we know that allergens are important in stimulating Th2 cells and causing allergic inflammation. How's this happening and why is this happening? So in their model, they're using papain as their inhaled stimulus. And you may remember back in your immunology days that this is a cysteine protease that's present in papaya. It has a lot of applications. It helps in removing dental caries. You may also put a little papaya together with your meat to help tenderize it. But it's also known for cleaving the antibodies into the fat fragments into the Fc portion. It seems to be an important cause of occupational asthma, and it's used in a lot of the mouse models for asthma, and is thought to be allergenic. And what we know is prior articles from the same group that intranasal administration of the papain in rag knockout mice, so these mice do not have B or T cells, these mice still develop lung eosinophilia and mucus hyperproduction. So this slide shows the histology of mice from wild-type mice that are rag knockouts, so they don't have the BT and NK cells, mice that lack those adaptive cells, as well as the ones that are missing the IL-2 receptor gamma. And as you may remember from a couple slides before, that IL-2 receptor gamma is really common chain, is important also for innate lymphoid cell development. So you can think about these mice missing the innate lymphoid cell group 2. And so they take these mice and they intranasally inject papain on days 0 to 2, and then they also heat inactivate the papain, so that is their negative control. And so these are lung sections that are stained with the PSA stain, and so it's staining for mucus. And you can see that in the wild-type mice, as well as mice that don't have the adaptive B and T cells, that you can see the mucus production of the sort of purple staining. However, this is critically absent in the mice that don't have the innate lymphoid T cells, innate lymphoid cells. And so it seems that these cells are important for the mucus secretion. And so they looked more carefully in these mice and said, well, let's see what kind of cytokines they're producing. And the black bars are the ones of mice that are treated with papain, and then the white bars are ones that are have the control. And this is in the BAL, so the lavages of the bronchial airways. And you can see that in both the wild type and the knockout mouse that they still have really actually very elevated levels of IL-5 and IL-13, which is notably absent in the mice that don't have the lymphoid cells. And so when they looked more carefully at what kind of cell populations infiltrating into the lungs and as well as in the BAL, you can see that there are increased numbers of eosinophils in the wild type and the RAG knockout mice, again absent in the mice that don't have innate lymphoid cells. Interestingly, it looks like there's actually an increase in neutrophils compared to that, the wild type and the RAG knockout mouse. So it may actually have, the innate lymphoid cells may have a role in actually suppressing the neutrophils as well. So basically, you know, in this model, you can argue, well, how are the innate lymphoid cells helping in Th2 development? And obviously, with the RAG knockout mouse, you can't really answer that question since they don't have T cells. So they did a really clever way of studying this. So as I mentioned a couple slides earlier, ROR alpha is a transcription factor which is essential for the group 2 lymphoid cell development. And there is a spontaneous mutation that knocks out that critical transcription factor called staggerer mice. And so effectively, these are sort of like our innate lymphoid cell 2 knockouts. The reason they're called staggerer mice is because they tend to tremor, they have a staggering gait, they seem to be smaller in size and have less tone. And it's due to the importance of this particular gene in causing development of the cerebral cortex and the Purkinje cells. Unfortunately, these mice is mainly a lethal mutation, so most of these mice would die within 2 to 3 weeks. So obviously, it's hard to use these mice for long-term studies with infection. This group also showed that the ROR alpha is not highly expressed in other hematopoietic cells, including T cells. So this is not intrinsically required for Th2 cell development. So to get around the fact that these mice would die early, they basically made a bone marrow chimera. And just to familiarize you with what that means. So you take a wild-type mouse and you sublethally irradiate it. So basically you're preventing the bone marrow from making new lymphoid cells and also killing the host lymphoid cells that are already circulating in the system. And then you inject into these mice bone marrow from the staggerer mice. And so it reconstitutes this mouse, but now this mouse has its own normal brain function, so it's not staggering, and now it has T cells, it has B cells, but effectively it doesn't have the innate group 2 lymphoid cells, so we can call these sort of like a knockout mouse for the group 2 population. So in this model, they take either the wild type or the IL-2 deficient mouse with bone marrow chimeras, and intranasally give 10 micrograms of papain or the heat inactivated papain on 0 and day 1, and then again on day 13 and day 20, and then they looked at day 21 for the immune responses. So again, this is sort of a busy slide, but now the black bars are indicating the wild type, and the white bars are indicating those that are mice that don't have the group 2 innate lymphoid cells. And so you can see that, as before, in wild type, you would expect to see lots of eosinophils, some neutrophils, macrophages, and dendritic cells. However, in these knockout mice, you get an absence of this population. And then when they looked at the T cell population, there was also a decrease in the CD4 helper population in the innate lymphoid group 2 mice, deficient mice. And so you can argue, well, is it that there's actually maybe a decrease in the Th2 cytokines that are being made? And indeed, when they looked at the actual cytokines in the lavage, looking at IL-4, IL-5, and IL-13, you can see that in wild-type mice that there is this nice increase of the IL-5 and IL-13. However, in the knockout mice, there's the absence of the IL-5 and IL-13. So it really looks like the innate group 2 cells are important in the induction of the adaptive type 2 immune response. So IL-4 has always been implicated as an important part in making T8 naive T cells into Th2 cells. So they asked, well, how about in an IL-4 knockout mouse? So that's the white open bars, and then the wild type is the black bars. And again, you see that there's eosinophils in the wild type, but there's maybe a little bit less than lung, but they also showed that in the actual lavage of the bronchial airways of these mice, they actually had comparable numbers of eosinophils. And really strikingly and surprising is that the CD4 cell seemed to be the same in both the wild type and in the knockout mouse. And so when you looked at the cytokines being made in the lavage, not surprisingly, the knockout mouse isn't going to make IL-4, but really what's, again, surprising is that you still have retained the ability of these mice to make IL-5 and IL-13 very similar to the wild-type mouse. And when you look at sera, really there's no presence of immunoglobulin E, and that's not quite as surprising since we knew from the past that IL-4 is an important switch factor for immunoglobulin E production. And then this is sort of a further proof showing that the innate group 2 lymphoid cells are important and essential for induction of the Th2 cells. So they took mice that were stimulated with papains on day 0 and 1 and looked at the mediastinal lymph nodes by flow on day 6. And so by intracellular cytokine staining, looking at IL-13, IL-5 positive cells and gating on them to look at which ones are actually our T cells producers of the CD4 type, you can see that there's a nice population in the wild type, which is really markedly reduced and quite frankly absent in the mice that are don't have the group 2 lymphoid cells. However, if you adoptively transfer back that subset into that mouse that's the bone marrow chimera, then you can restore that ability. And this graph here really shows you sort of the raw absolute numbers so that you can see that there's a decrease in the mouse absent of the group 2 lymphoid cells. When we put it back, and now you get an increased number of Th2 cells in the mediastinal lymph nodes.
Audrey, I hate to do this, but I think we're going to jump to conclusions. And
Absolutely. So basically, I said that IL-4 is not as important, but really IL-13 seemed to be the most important aspect of it. And what's important is it helps promote the migration of the lung dendritic cells into the draining lymph nodes, where they help prime the naive T cells into Th2 cells. And what I didn't show you here is that it seems to be IL-33 dependent. So basically those are made by the epithelial cells, and then in turn the innate lymphoid cells respond to it and make the IL-13. So this is basically just a summary model showing what the paper showed. So with papain, it allows the epithelial cells to be activated, making different sort of cytokines, particularly the IL-33, which acts then on the lymphoid cells to produce IL-13. This makes the dendritic cells migrate into the mediastinal lymph nodes, which then activate those T cells into Th2 producing cells. And the question is, how else is it affecting other cell groups in the airway? And as I mentioned before, it seemed like those mice had increased neutrophilia when they were when the group 2 cells weren't there. So how is it actually suppressing that neutrophilia will be wait to be determined. And so then finally, really the point is eventually we need to be able to look at what these cells are doing in humans. And what we've seen so far is that in humans that are asthmatic, there does seem to be a very similar innate lymphoid cell group that produce IL-13, IL-5 that aren't found in healthy patients. They express receptors for IL-33 and TLCP. They seem to increase in response to allergen inhalation, and they seem to be also found in the gut and skin as well. And as I mentioned before, they're found in the nasal polyp tissue cells. So I think, this is really a hot topic in the mouse world, but I think it's something that's incredibly pertinent for us as immunologists, allergists. So wait to see what happens.
I don't have that much. Even though I have a lot, let Bill talk, and then my talk, people can just read my slides. I have a few that I do want to do. Don't worry, I'm not worried.
Bill, you want to go next?
Can I ask a question first?
Audrey, with this amphiregulin, is there any evidence that in asthmatics that their airways go back to normal? Has anybody looked at amphiregulin in terms of an asthmatic getting better versus getting worse?
That much about that.
And what happened to the old TH0 cell? Is that the same as this ILC2 cell?
No, these are completely different. These are
So
completely,
TH0 cells just
are almost, yeah, ones that haven't quite, they're not committed to a particular cytokine profile. So these aren't even T cells. These are a whole new breed of innate immunity.
Really T cell communities, yeah. So exactly, different classes of Th1, Th2, Th17. Some of them also secrete IL-10, so they're also Tregs. So why aren't they like PCR negative T cell? Recently was an imitation described in B cell where you get T cell without PCR. So they can just escape some regulatory mechanism that prevent them from going out into the
When they
country.
looked at different receptors, I didn't go through it. I mean, they really, truly do look different. I mean, they looked at a lot of different receptor expression that you would think might be part of a T cell, B cell, and they don't express that. I really, truly think they're different.
Is there any particular relationship between the toll-like receptors leading to stimulation of the ILC? I mean, you did mention that dendritic cells are in epithelium, and there are some toll receptors in epithelium, but you went through a whole talk on innate immunity, and I didn't think I heard toll receptors.
Yeah, they didn't.
Toll-like
Surprisingly,
receptors.
they haven't really talked. I mean, at least the articles that I've looked at, there's not as much on there. I mean, this is pretty budding, so I think right now they have looked. I mean, they could have, but at least the articles I looked at, I did not focus on that.
But it's clearly not adaptive.
Correct. Correct. But they're critical for the bridge to allow adaptive immunity to occur.
Go ahead, Bill.
Okay, well, after I saw Audrey's nice presentation yesterday, I pulled an Audible and threw in a ILC2 paper from Immunology also, since I never would have been able to pull it off without that really great introduction. So what I'm going to focus on is bee venom phospholipase and how it induces a Th2 response via IL-33 signaling, inducing activation of these ILC2 cells. So this is a brief introduction to what these phospholipases are. If we look in the normal stimulation of a cell, let's say a mast cell, you think of a cytosolic phospholipase A2 that leads to production of prostaglandins via the cyclooxygenase pathway, or activation of 5-lipoxygenase to form glucotrienes. And what's been recognized more recently are these 10 mammalian secretory PLA2s that are small molecular weight that are released from the cytoplasm to the outside of the cell, so they can be potential targets here. And they did the same thing. They split off arachidonic acid from membrane phospholipids, and you also get a lysophospholipid that can be metabolized into platelet activating factors. So, very potent, key kind of regulatory enzyme here. So they're upregulated by inflammatory signals, and primarily they've been thought of for leading to leukotriene and prostaglandin formation. So if you look here at the families, the snake venoms, the old world like cobra venom are type 1. And then if you go down, type 2 are the new world like rattlesnake venom. Type 3, these are all variations on the same theme based on their cysteine composition. Type 3 is the bee venom, phospholipase, and 5 and 10 are actually the most potent in inducing arachidonic acid. So those are the ones involved in asthma models, and we've shown that in mouse models, and also now Teal Hallstrand here at UW in humans being very important in in exercise-induced asthma, release of the secretory phospholipases 5 and 10 for that. But what we're going to focus here right now is on this group 3 here, which is the bee venom phospholipase. And as we know, this is a real potent antigen for inducing anaphylaxis. So in these studies, I've just got 2 slides on this because it's maybe like 10% of the data that's presented in the paper. But the key points here are that they used a novel mouse that Rich Loxley, who was formerly here many years ago during his fellowship with Seymour Klebanoff, he developed these reporter mice that have got this green fluorescent protein that's been into their germline so that their T cells express it, and you can track them. So you can give, in his studies, he gave a helmet, and you can follow these green fluorescent T cells as they migrate from the draining lymph nodes to various target sites. It's a powerful approach for looking at in vivo trafficking of activated T cells. So they immunized these mice sub-Q with 100 micrograms of bee venom, and then they looked in the draining lymph. So this is an innate immune response that they're looking at, because the effects are short occurring within 4 to 5 days. So they took them out, and in the upper, this A panel, they then isolated the T cells in the lymph node. They were expressing these IL-4 by this green fluorescent signal. And they showed that if you just focus here on the phospholipase, the bee venom one, there was a marked expansion from 5% up to 12% of the population were expressing IL-4 by that. And then they did, they isolated T cells and they incubated them in the presence of the bee venom that had been injected. And they showed this marked expansion of IL-4 production in the in vitro. And then they injected bee venom into the peritoneal cavities in this bomb thing, and they took out the serum and found that they were a very potent inducer of IgE and IgG1, which is also dependent on IL-4 signaling. So they then showed that this response, this T cell, this expansion of the T cell population by just injecting bee venom into the mice was dependent on the phospholipase activity, because if they heat inactivated it, here they lost this expansion of the T cell population in the draining lymph nodes. And this is all due to, if you look at this last far over here, the phospholipase E2 is cleaving membrane phospholipids. You're releasing arachidonic acid here, and what's left is the lysophospholipids. So in this case, it's lysophosphatidylcholine. And it turns out this is the active part of how the bee venom is doing it in this kind of a toxic way. So they, in another set of experiments, they showed that they injected lysophosphatidylcholine into these mice so they could also get this expansion of the T cell population that was dependent originally from the original bee venom. And they also showed that all these other types of phospholipases, such as cobra venom or rattlesnake venom, also mediated the same effect. And what it turned out is that it's a toxic effect of the venom in that you need the cleavage of the arachidonic acid to form this lysophosphatidylcholine, and then the lysophosphatidylcholine injures the membranes of target cells. And that in itself is a signal for this IL-33. IL-33 is different from the other cytokines that Audrey was mentioning. TSLP and IL-25 are also coming from the epithelium, but they are transcriptionally regulated, so other cytokines can upregulate them. But IL-33 is constitutively expressed by the epithelium, and it's thought only it's with apoptosis or some sort of cell injury to the epithelium does it get released. You can't amplify its response. So in this case, in this other set of very elegant but complex experiments that they did, they showed that the release of the bee venom via lysophosphatidylcholine was inducing release of IL-33 from in these mice. It's a very complicated story, and the way they showed that was that IL-33 signals via this. Yes, is that showing up there? Good. It has a receptor on a variety of target cells, which is called ST2. So in these animal experiments, they were able to utilize mice that are deficient in ST2, and therefore you can block IL-33 signaling. So based on that, they knew that bee venom induced lysophosphatidylcholine. The enzyme itself needed to be active. You could eat and activate it to destroy this immune response. And that it also showed that they signaled via this ST2 receptor, therefore implying that IL-33 was involved. So then they had already injected these bee venom into the peritoneal cavity. They isolated the peritoneal fluid and showed that there was a marked increase in IL-33 that had been released into the peritoneal cavity. So then they, as I just mentioned, IL-33, its key thing is activating the innate cells type 2, these innate lymphoid type 2 cells, ILC2s. So in this, I want to get to another part of my talk, but I think that the main part here is that they've been showed by this FACS analysis that if you gave the bee venom to the mice, you got the expansion of the ILC2 population in the peritoneum after you had injected the bee venom or the lysophosphatidylcholine. And that if you then heat inactivated, in this case LPC, that you decreased the ILC2 population. So this was gating on them there. And the ILC2s, they are primed for producing IL-5 and IL-13, which are both good for getting eosinophils in. You can see that the wild-type mice that can signal through IL-33 via this ST2 receptor have a lot of eosinophils in their peritoneal cavity, whereas in the knockout mice that can't signal through IL-33, they have a marked decrease in that. So it was a very interesting paper showing that bee venom can induce antigen-specific IgE against itself. It does this via stimulation of T-cell populations in a very rapid form, 5 days after injection into the mice. The whole process is required for the signaling via phosphatidylcholine, which is a byproduct of the phospholipase enzymatic activity on phospholipids. That in turn leads to this release of IL-33 from the epithelial cells or other target tissues. The IL-33 signals via its receptor to activate these innate lymphoid cells type 2, which then produce IL-5, IL-13 to markedly ramp up the inflammatory response. So it's just another example in our field of this new population of innate lymphoid cells that are potentially very pertinent to, in this case, anaphylaxis.
Bill, if you translated that to a human model, why doesn't everybody respond to bee stings in an anaphylactic way?
Well, I can't answer that.
But is this just priming the production of antigen-specific IgE? I mean, or is this actually inducing the...
This is inducing antigen-specific IgE.
Right. And so I'm sure there are several more steps still from this
for regulation of this, yeah.
To this
I guess the answer is in the genes. Right.
Are there any markers on these ILC2 cells? I mean, obviously we have 200 markers.
They're CD45 positive, and then another marker called LIN, L-I-N negative, and then another 90.2 positive. So that's how you gate them for the FACS analyses by these antibodies against those different molecules on the surface. So that's how you can get this gated population right here that in those mice.
Where have they been all of our lives?
I'm sorry?
Where have they been all of our lives?
Yeah.
Are there very minor component of the lymphoid cells, or?
Well, with regard to the population, they didn't specify that because these are all like expansions, but I didn't see like relative number. Do you remember, Audrey, of their predominance?
I think you said they've been ignored.
Well, even though Mary said everybody's dying.
What time are we here? Okay, so these would be easier to describe. What I wanted to talk about was eosinophil esophagitis. We're seeing more and more of these as consultations, and I'm having a hard time with this because I find the literature very confusing. And so I wanted to see what was up currently, and there was actually 5 or 6 papers in press on this topic. This was an intriguing one. They noted there was some survey in the literature where physicians thought there was an increase of the diagnosis of eosinophilic esophagitis in patients from a rural area residents. So these people from Chapel Hill and UT Southwestern took a national database from a pathology lab that gets most of this, I guess, a ton of samples. They had like 100,000 patients where they had esophageal biopsies that were read by this one company. And then they did a zip code analysis of looking at the number of cases of eosinophilia greater than 15 per high-power field as one definition. And then they did a more stringent, that was like 80,000 patients. And then they had a case definition of 15,000 patients that had EOE plus clinical symptoms and where they had excluded Barrett's esophagitis and GERD things. So I don't know how they analyzed all this data. It seemed quite incredible. And then they did this longitude, latitude pinpointing of where all the patients were coming from. And they noted that the patient, compared to the patients ended up with normal biopsies, the EOE patients were younger, but this is an adult population, so the age here was, I think they're in their 40s. What was it? 50. The EOE patients were 45 versus 54, and the patients ended up with normal biopsies. 64% male, and then they had the higher proportion of dysphagia. And what they found is that this physician survey was replicated in this big database thing that as population density decreased, the odds ratio for eosinophilic esophagitis increased markedly. Their reference population was big urban areas. And so it was similar to, and the other thing that was interesting was that the big predominance of EOE was in the West and in central U.S., looking at the orange-red areas. The eastern seaboard was, they said, relatively spared significantly for a diagnosis, underrepresented. So they added this to the things that like multiple sclerosis, which is, predominance in northern areas. Puget Sound is a particularly big area for MS. So it's one of a handful of diseases now where it's got a geographic distribution. They speculated exposure to herbicides, insecticides, livestock in the west and the central regions, but there's no just a provocative study here.
Do you think that the GI people on the East Coast maybe don't biopsy as much? You know how for a while, like a lot of adult GI docs weren't biopsying? I mean, at the time when they were doing this?
Philadelphia is a big for this. I think they're looking for it just as much as we are. And Cincinnati, both of the East Coast, is where most of the work comes from.
Yes, all the areas of the country were well represented, that were Same here.
Exposure to pollen.
Just the numbers kind of speak for themselves, 15,000 patients. So.
There's some thought by exposure to pollen, the diagnosis of DOE could go up during pollen season. Did they look into that? I don't know. It doesn't look like they did, but
They said they factored out for climate zones, but I don't know if that would take into pollen.
Right.
Because they did another fancy analysis in the supplemental data I didn't read, but they commented that the climate didn't make a difference.
Mary, how much time do you want to save for you?
You can give me like 10 minutes. You know, another 5. I really don't. I mean, I can like whittle mine down.
This one we can. This was just one study. When I read through it's crazy. There's hardly anything known about the natural history of EOB. This study was a single study from University of South Florida. One GI and pathologist who collected 13 cases over from a 5 to 25-year period. So in adult, they were like, there'd only been one other study in adults looking at like a 5-year follow-up. So in this one, they showed that they all had daily dysphagia, and 12 had presented with food impaction. In this case, it just shows you that the disease is hard to characterize. This one, half of them had Barrett's esophagitis. The other study had excluded that as a criteria for EOE. But anyway, they found that the symptoms persisted over that whole time. They were did well with dilations. If looking at the luminal diameter with, on average, 3 dilations the first year and 2 per year after. So they had maybe from 10 to 20 dilations, and they were able to get them up to, most of them up to around 16 to 18 millimeters in diameter. So they say that you need 16 in order to have a fairly good quality of life, and then you can have an unrestricted diet at like 18 millimeters luminal diameter. These are all, what was unique about this is they're all steroid naive. So for up to 25 years, they did pretty well, just they had one perforation from the dilations in 1,000 procedures leading to one hospitalization. No patients developed malignancy from their Barrett's. And that was the preamble to this major one from Mark Rothenberg's group, came out in gastroenterology. They did from most of the patients were Cincinnati, but also Utah, Children's Hospital of Colorado, and CHOP. And there was 51 patients entered into the study. It was this multi-site double-blind placebo where previous studies had shown that 880 micrograms of fluticasone swallowed led to about a 15% complete remission in eosinophils in the biopsies. So they wondered, could they increase it by doubling up the dose? And this is primarily a pediatric population. Mean age was like 12. They range from 5 to 25. And so if we go to the next one. Didn't show too well, but it was phase 1 was 3 months on placebo or this double dose of fluticasone, 1,700, whatever, 60 a day. And it was randomized 2 to 1, so twice as many got the fluticasone. And then at the 3-month point, the people, their criteria was a complete response was histologic, less than 1 eosinophil in the proximal and distal duodenum, esophagus. And the people that had more eosinophils at 3 months, then they either continued them on. People that were in complete response, they decreased the dose in half. And the people who've been on placebo for the first 3 months were all moved over to the 1,760 dose for the next 3 months. And just the take-home points here is that they had used a variety of criteria for the complete response, but most of them, bottom line, the placebo led to no change in the eosinophil numbers in that group after 3 months. And was about 65 to 70% on the double dose fluticasone compared to prior studies had a complete histologic response. And 2/3 of those were maintained by decreasing the dose by 50%. That other group there was the ones that relapsed. So they also don't have time for this, but they've done these transcriptome analysis. They've done microRNA analyses of their biopsies, and they showed that the people in complete response, if you're looking at the blue here, look more like the normal group than they had been compared to the patients where a lot of the genes are in yellow. So take-home points of this is that the trouble is it was underpowered for symptoms, and they didn't require symptom activity to be a requirement for entry into the study. So it's pretty much suppression of airway histology of eosinophils. You can achieve it in this population with high dose, but you also, 7 of the 8 study subjects that were on the high dose developed a decrease of their salivary cortisol levels. So in my mind, I'm not a pediatrician, but I don't quite understand this because you're probably going to have major effects on growth with this treatment. There was no difference in from placebo in the symptom scores, even though it was underpowered, but you did create complete remission of the eosinophils trafficking into the esophagus. So I think it opens up a lot of questions for clinical practice.
Let's, however, hold the question to get Mary up there. I don't know which one she wants to do first, but since SLID has been released, it's kind of good for us to start a discussion on that subject in the community.
Go with that. So I'm not going to do that one first. Sorry, you can read them. Okay, so the one I do want to present, it has nothing to do with allergy, but I just think it's really, as physicians, we all need to know about this new product that's out for hepatitis C infections. And this was just published like 2 weeks ago in the New England Journal. And there's actually three studies. 2 of them are online, and the other one is the one that's in the journal. So anyway, this is a phase 3 randomized open label study that involved patients that had hepatitis C who had been previously treated with PEG interferon and ribavirin, and they had not mounted, essentially they weren't cured yet because with that treatment. So there are 440 patients that were randomized to receive this once daily fixed dose combination of, and I'm not going to even say the names, LDV and then SOF, okay? And so it's a combined pill, and then they did it for 12 or 24 weeks, and they did it with or without ribavirin. And the primary endpoint was sustained virologic response at 12 weeks after the end of therapy. And so the results of this pill, this once-a-day pill, is that it's capable of suppressing the virus at rates greater than 90%. And if you look at the 12 and the 24 weeks compared to the ribavirin, really there's not much difference. So the pill by itself is enough to sustain or to suppress the virus. And when you looked at this study population, about 20% of the patients had cirrhosis that were enrolled in this study. And the patients that had cirrhosis, they did not have as good of a response with just the 12 weeks. But at 24 weeks, it was like 99% cure rate. 11 out of the 440, so 2% had a virologic relapse, and those were patients that were treated for 12 weeks, and no patients treated for 24 weeks had a relapse. There were mild to moderate side effects. The side effects were usually fatigue, headache, nausea, but nothing that made anyone stop the study. And the patients that actually got the ribavirin in conjunction had many more side effects, so more fatigue, nausea, insomnia, arthralgia. So by itself, without the ribavirin, it looks like it's a really good product. There are over 3 million Americans infected. It's really kind of that baby boom. It's my age and up, and 75%, or between 50 and 68 years old, it accounts for 75% of the hepatitis C infection. And the mortality of hepatitis C is more than HIV in the U.S., and 1/3 of Americans have advanced cirrhosis. This is a revolutionary treatment for hep C, but is really expensive. So for this combination product, there's 2 pills essentially in one. It's $1,000 just for SOF, and that doesn't include the other product. So for a 12-week regimen, it's $84,000. And Gilead is the makers of this product. There's another product, and it's called, well, the company is AbbVie, and they also have a product coming out. And so the reason I wanted to bring this up is I was out with my friends this weekend, and one of my dear friends is a surgeon, and he's a general surgeon. And we were having this whole conversation at dinner about this product, because essentially, he said, well, first of all, if you're a surgeon and you get Hep C, your life is over. You cannot practice surgery anymore. So for him, I mean, you know, this will revolutionize, you know, for surgeons, if they ever did contract Hep C, then they can still practice medicine. The other thing is, as we were talking about, is that for the prison population, I don't know what the percentages of, but it's a very high amount of Hep C. And then we were talking about, he said that if prisoners are in prison for so many days, then essentially their medical care comes through the state, through the government. And so essentially with this product being so expensive, like how do you, anyway, but anyway, I just want you to know that there is this product out there, and this is going to change Hep C.
Is your 1/3 of Americans with Hep C have cirrhosis, or 1/3 of all Americans have cirrhosis?
Oh, 1/3 of Americans with Hep C. Sorry.
I feel
Yeah.
bad.
Okay. Sorry. Yeah, I could have qualified that. Oh, you keep me on my toes. Okay. And then I got rid of the second. All right. So then, okay, and then now back to allergy. So I kind of wanted to just do, just because there's these 2 products that have come out just recently, the Grass Tech and then Oral Air, which are the new Grass Sublingual. And I kind of wanted to just pull some of the more recent studies just to see, like, okay, how is it supposed to work? So this was a study done in 2012. It was published in February this year. It was a multi-center, double-blind, randomized, placebo-controlled trial. It was 1,500 patients aged between 5 and 65 who had grass, allergic rhinitis, and conjunctivitis. And it was a 1-to-1. Either they received the medicine, the Grass Tech, or they received placebo. And there was almost 300 kids that people under age 18. And these patients had to have a positive skin test to grass. They had to have immunocap tested, and then they had to have an FEV1 greater than 70%. And patients with severe asthma were excluded. And the thing when you read the paper, essentially, they can have asthma, but they can't be on treatment. So for me, it's just like mild intermittent asthma. They couldn't be on like daily asthma meds. So if and I don't know if Singular counted as an asthma med, if Flovin, or which, you know, I'm not sure. They didn't have that in the paper. These patients had to start this Grass Tech or the placebo 12 weeks prior to the grass season, and then they looked at their total combined score. Okay, so this is, let's see, the green. Where's my little pointer? Okay. This is the grass pollen counts, the green. These lines here, this is the tree pollen. So as you know, tree pollen is waning, then the grass pollen goes up. This line up here is the patients that are on placebo, and this is their total combined score. And then these are the patients that are receiving the Grass Tech. And this is looking at the. Oops, sorry. Oh. I'm sorry. This is the slide, or the graph in the bottom is just looking at how they figure out the scores. So the daily symptom scores, patients when they came in, they had to say whether or not they had a runny nose, blocked nose, and they would rate it from 0 to 3. And then the medicines that they used as rescue during the study. So the total combined score during the entire season, there was a 23% improvement. And then if you look at peak season, there was almost a 30% improvement in the patients that received the Grass Tech. The one thing about this study is that the 2012 grass season was a very weak pollen season. And that leads to the next study that we're going to talk about. But this is just the side effect profile. So there were 7 systemic reactions in this study, 2 for placebo and 5 for those who received the sublingual product. The most of the side effects are mostly throat irritation, oral pruritus, mouth swelling, and itchy ears. Only 3 out of the 5 patients had required treatment with epinephrine. So these patients, when they get the product to go home with, they are sent home with an EpiPen.
Mary, how do they get a systemic reaction on placebo?
Well, you know what? Because they complain about. I can't remember.
Well, it's not. Don't
That's
stop.
all right. We'll let Audrey look through it. because they complain enough of.
So it's complaints. It wasn't objective data.
I can't remember.
But most of that stuff.
I read it last week. I can't remember. I'm too old. And so okay. So then they because it didn't. It didn't look that great, right? Because at 30%, you're like, yeah. So then, but they realized that the grass pollen season, when they did that study, was a pretty weak season. So then they did, Steve Derms and others did a post hoc analysis of data collected over 6 trials in Europe, including this one in North America and 7 grass pollen seasons. And so they looked at almost 2,400 patients. 40% of the subjects were from North America. And the grass pollen counts can vary. 50% of the days during the grass pollen season had grass pollen counts above 30 grains per meter cubed. In that original study, the mean grass pollen was like 23 grains. So it was just a pretty weak grass season. And so they took this data. This is the, here's all the grass pollen grains that counts. And then this is the people that were on placebo, and then here are the people that are getting the grass tech. So higher the pollen count, the higher the total symptom score, combined score. But the magnitude of the treatment effect, the difference between the placebo and the treatment arm was greater when there were higher pollen counts, which makes sense. And then even in trials with the same product, efficacy can vary depending upon the seasonal variation in grass pollen. And grass pollen exposure during the first part of the season is a better predictor for magnitude of treatment effect.
That curve earlier is not all that different than the classic ragweed studies from Johns Hopkins 40 years ago. So my feeling always was that this was less effective than subcutaneous, but the truth of the matter is 30% is pretty good.
Yeah. And then this is, I just didn't want to focus entirely on the grass tech product. So this was Linda Cox published this in 2012, and it's looking at the other product that's now available, the Allergen product, Oral Air, and this is the 5 grass pollen tablet, and there were almost 500 patients. These are patients that are adult, they're enrolled, and they essentially were on the product about 4 months before the pollen season began. And then same thing, this is, looking at, this is the grass season, here are the patients that are on placebo, here are the patients that are on the Oral Air product, and then about the same thing, about a 30% improvement, depending for their total combined scores. And then Hal Nelson did a nice review, just looking at the U.S. experience, and so essentially he's just showing that there's very little serious reactions, and then it was just a nice paper. He also included products with ragweed and then for dust mite. And so then I just put this together. I kind of pulled out the package inserts and trying to just kind of get my head around comparing the 2 products. So Grass Tech is the Merck product. That's the single Timothy grass, and then Oral Air is the 5 pollen mix. And for the Grass Tech, it's been approved for 5 to 65-year-old range, whereas the Oral Air is for 10 and up. The first dose for both products has to be administered in the office. They're both sublingual tablets. They usually dissolve under your tongue within the first minute. The Oral Air product is it's a building up dose. So you do on day 1, you do a third of the dose or 100 international or index reactivity sublingual product, and then day 2 you do 2 of those, and then by day 3 you're up to their standard dose. If you actually look at the BAUs, the Timothy grass, this is 2,800 BAUs, whereas the 5 pollen mix, the 300 is about 9,000. So it looks like this product is a little bit stronger. For the grass tech, you should initiate treatment at least 12 weeks before the onset of grass pollen season, and you can continue through the season. And it also can be done as a daily product, and they've done studies in Europe up to 3 years. Whereas the oral air product is 4 months before the onset of grass season, and you continue through the season. But I didn't see anything about that you stay on it year round. They both are pregnancy category B, but should only be used if necessary. Asthma, there's no study in patients with moderate to severe asthma or any patients on daily meds for asthma. So, and then the contraindicated meds. The other thing, which we've had discussions about, is if you read the package insert, it's that, oh, never mind. It's that funny statement about how, yeah, I wanted to read that. It's,
and the FDA put strange wording into the package insert, but
yeah, okay, so it's not on that one, sorry. It's just, yeah, no.
Why did it leave a contraindicated med?
It's just in the list. I have, yeah, it's just in the list. I just pulled out what they said was contraindicated, but they don't give you a reason. They just say those are the meds that are contraindicated. Yeah. Oh, here, this is it. Both oral air and grass tech say may not be suitable for patients with certain underlying medical conditions that may reduce their ability to survive a serious allergic reaction. That's directly taken out of the package insert. Okay. And then case report. There was one case going along with Bill. There's a case of eosinophilic esophagitis, EOE, induced by grass sublingual. It was a 23-year-old man who was with dust mite and grass allergy. He had been on dust mite slit for at least a year. 2 months before the pollen season, he started on the grass. 1 month later, he started having dysphagia. He was started on PPI. His symptoms kept worsening. He figured out it happened after his grass tablet. He stopped the med, symptoms resolved, and then he restarted the med, and 1 week later his symptoms recurred, and he underwent a EGD, and they found a high number of eosinophils. And then this was just a sublingual IT. There's a WA position paper that came out. And then, so there's a lot of unanswered questions. So, is slit safe in moderate to severe asthmatics? Is it safe for patients who've had systemic reactions to subcutaneous immunotherapy? What about if your patient's on it, but then they stop it after a week? Do they start it again in your office, or can they do it at home? Is it really, truly safe in pregnant and breastfeeding women? What about younger kids under age 5? Patients who have immunodeficiencies, patients who have mouth lesions or have had recent surgery? And when should your dose be held? Like if you've got GI bug or something.